All right. So can you hear me?
Yes, a little louder if possible.
Yeah. So I will add to the confusion that Kavita and Satyan started. And Kavita beautifully showed the picture where MIGS is a small baby standing in the corner. Beware, maybe in a couple of years, it will try and fight to occupy the central chair. So if you look at the glaucoma management, the paradigm of treatment is most of the glaucomas are treated medically, close to about 90%. And then in certain situations, we do use lasers. And once that fails, or when you read better pressure control, we do go in for surgeries. And surgeries most often that we use are trab and tube. That is what we just heard. Definitely, the mitomycin C has improved the success rates. And looking at the complications that Kavita and Satyan showed for each other, against each other, we know that both have problems. So we know that as time goes by, bleb-related surgeries do have a lot of complications related to the blebs, and tubes are no far away. It's apart from the intraocular pressure that you're worried about, you do have a huge implant sitting in there, and that can cause a lot of problems, whether inside the eye or outside the eye. So the question that occurs to us is, can we avoid these complications? And what do we do to avoid these complications? Do we modify our glaucoma filtering surgeries, or do we have alternative surgical options? So the topic that is the MIGS is otherwise called as minimally invasive glaucoma surgery. There's nothing minimally invasive, so maybe you will put it as micro-invasive glaucoma surgery. What does this do, and what are we looking at? What we are trying to see is, can we improve the physiological outflow of the aqueous through the trabecular Schlemm's canal and the collector channel pathway, where you can do a procedure with no bleb and possibly no bleb related or hypotony related problems, because you don't want too much of a pressure control. And majority of these surgeries can also combine with cataract surgery. So you're looking at better safety profile and also looking at moderate intraocular pressure control. There are multiple MIGS procedures that are available. They are majorly divided into ab externo and ab interno procedures, and several of them that are actually being used in the West are ab interno procedures. So what are these procedures? And for easy understanding, because we don't do several of them in our country because they are not available in our country, and the cost is a huge factor. But to understand what are these mixed procedures, basically, if you look at the drainage of the aqueous, after it is getting produced, it drains through the trabecular meshwork. From the trabecular meshwork goes to the Schlemm's canal, from the Schlemm's canal to the collector channels, and the intrascleral, the plexus and the aqueous veins, and that is how it moves out. So you are targeting every one of these areas, that is the Schlemm's canal opening as well as the trabecular meshwork. So in open angle glaucoma, we know that the problem is at the trabecular meshwork. There is a resistance that is offered at the trabecular meshwork. So you're trying to use procedures that can bypass this trabecular resistance. And once you do that and reach the Schlemm's canal, apparently, if everything else is okay in the aqueous pathway, the intraocular pressure is likely to control. And there are alternate pathways like the suprachoroidal pathways, where you know that in, let's say, in a complication like a cyclodialysis cleft, you do have significant decrease in intraocular pressure to an extent that it goes into hypotony. So can you try and do a controlled kind of a drainage into the suprachoroidal space where you have an alternate pathway to reduce the intraocular pressure? And of course, the subconjunctival procedures where you're trying to modify a non-conjunctival touch kind of a procedure like the Zen, or a minimally invasive procedure like the InFocus. So these are all the ones that are available, and there are several others that are there in the experimental stages, and we don't have them yet available for us after the clinical trials. So there's a huge list of things, and I will just take you through a few of them. And like was mentioned, definitely there is a decreasing trend in trabeculectomies in the West, and the implants are slowly increasing or almost remaining stable, whereas the mixed procedures are increasing. And these mixed procedures are not just being done by glaucoma surgeons, but in fact, most of them are being done by the cataract specialists, and they are always combined with the cataract surgery. So it's also called as Phaco-plus. So what do you do here? Whenever you do a phacoemulsification, what they're trying to do is do a slight modification of the procedure at the end of phacoemulsification. Try and use one of these devices to try to bring down the intraocular pressure just by a little bit. And their major aim is to decrease the number of anti-glaucoma medications that the patient is using, not to completely stop the anti-glaucoma medications. And here you need to remember that a caveat here is that this is most often offered to patients where the pressures are under control on medications and patient is undergoing a procedure. So your intention is to bring down the number of medications, but not as an alternative to medications or an alternative to trabeculectomy or a tube. For mixed procedures, what is it that we need to know? So what we need to be aware of is definitely good anatomy, and one needs to be comfortable using a surgical gonio lens. So looking at the gonioscopic view of the angle during the surgery is very, very important. Identifying the structures is very important. And to be able to use a direct gonio lens, so those of who are pediatric surgeons who are using these lenses to do a goniotomy or any other procedures may find it easier, but even otherwise it's not difficult to learn. So you have both direct as well as indirect lenses that are being used. For the direct lenses, you definitely need to make the arrangements of the scope adjustments and things like that to be able to visualize the angle. And for certain indirect lenses, we can try and do it even in a primary position. Identifying the Schlemm's canal or the area of the trabecular meshwork is very, very important. And one of the tips is that if you are able to see the blood in the Schlemm's canal, that will give you a definite identification of, and it's a marker for you to know that this is the area of the Schlemm's canal, and you will be able to do the procedure appropriately. Other consideration that one needs to have while doing or considering mixed procedures is that one should know that the Schlemm's canal that is present as a 360-degree around the limbus is not a continuous channel. There are certain breaks in the Schlemm's canal, and these collected channels may not be present all over, and they may be present in certain segments. So whenever you look at MIGS, in fact, when there was a clinical trial that we were supposed to do many, many years ago with the eye stent, the trial design itself was with 2 eye stents versus with phacoemulsification versus simple phacoemulsification. So at that time, we were not aware as to why people were using 2 eye stents. So one of the reasons why what they had quoted, and that we understand now, is that we do not know when we use a single eye stent whether we are very close to these collector channels. So although we bypass the trabecular meshwork and let the fluid reach the Schlemm's canal, is this going to get out of the Schlemm's canal in a proper way? So that is a question that is always there. So what we understand is that the infranasal area has maximum collector channels, and that is the area that is targeted. And that is also because when you sit naturally and when you try to do the procedure, it's easier to target the nasal area. And that is something that we need to understand. So the eye stent is one of the things that has been there for a very long time. This is a 1 millimeter long tube, which is a titanium device, which is used to, if you look at the picture here, this is the angle view. You see the snorkel-like thing where the tube, where the opening is into the anterior chamber and the stem is inserted into the Schlemm's canal. And this is placed in position there, and there two of these are inserted to be able to drain the fluid by bypassing the trabecular meshwork. And if you look at this slide here, they have gone through a huge number of iterations, and there are several new generations that are coming up starting from 2012 onwards, and new ones are there in the market. iStent, iStent Inject, iStent Supra, and now you have iStent Infinite. The other device that is available for bypassing the Schlemm's canal is the hydrous implant, which is a little larger one, and it almost occupies about 3 clock hours of the Schlemm's canal. So it's made of a biocompatible material, which is highly elastic, which is called nitinol. And it has a posterior opening, and anteriorly there are 3 openings. So here also it is similar to that of the iStent. You see that a tiny opening that is left in the anterior chamber, and the rest of it is placed in the Schlemm's canal. It not only allows it to reach the Schlemm's canal, but because of its size and its location, it also tries to open up the Schlemm's canal or enlarge the size of the Schlemm's canal. The other group of surgeries which are kind of being performed, or possibly this is one group of surgeries which I think even in India we are doing. A few of us are doing, and we have access to these procedures. But the other ones, I said, these stents are quite expensive and they're not easily available in our country. What we do here is trying to open up. So the trabecular meshwork is what is trying to give the resistance, try to remove the trabecular meshwork. You can do that by either using a suture or a needle or a blade, or using a microcautery to be able to do that. So 360 trab or omni is something that is ab interno procedure where you're using a proline suture to go and uh, enter into the Schlemm's canal. You can, so there are two types of techniques here. Either you can go and dilate the Schlemm's canal and come out, or you can dilate it and try to rip open the inner wall of the Schlemm's canal. So by doing so, you're trying to give access. So it's kind of a modified goniotomy, if you want to call it as. Ab interno trabeculotomy or the trabectome is nothing but doing the similar kind of a thing, but using a high frequency electrocautery. And you are trying to ablate the inner wall of the Schlemm's canal. By doing so, you are allowing the fluid to reach the Schlemm's canal by ablating a portion of it. Cahuck dual blade is another instrument that is available, and this is something that at least we have some experience with, where this it is a blade with a very sharp tip, and it has a ramp which has the cutting edges. So the sharp blade is trying to be, when you try to insert it into the area of the trabecular meshwork, you're trying to actually de-roof it by removing the area of the trabecular meshwork. So by about 3 to 4 clock hours or a little larger than that is something that you can try and remove. And this ramp is used not only to cut the area of the trabecular meshwork, but also tries to collect that torn trabecular meshwork, and then that also can be removed from out of the eye. So I'll just share a video here. This is again combined with phaco-emulsification. So you do the phaco the way you normally do. At the end of the procedure, the eyeball is filled with viscoelastic, and if it is under topical, it's quite easy. You can ask the patient to actually look towards the nasal side, and if you're sitting temporally through a temporal clear corneal incision, you can use a direct gonio lens. It's a Schwann-Jacob lens, and you can insert the KDB blade through the main phaco incision itself. Trying to look at the angle. So you can see tiny little iris processes there, and intermittently you can actually see the blood in the Schlemm's canal. What is very important when you're trying to do this procedure is don't try and press this lens on the cornea. When you start seeing folds on the cornea, it becomes very, very difficult for you. So once you insert the blade inside the eye, you just have to place the lens over the eye. So that means viscoelastic is actually trying to form a cushion between your lens and the cornea. You can see actually pieces of blood in the Schlemm's canal. That beautifully gives you the area where you're supposed to insert. So you're trying to pierce with the tip and then try to remove a scroll of the trabecular meshwork. You can do this multiple techniques by trying to ask the patient to look in different directions, as well as by moving your lens. The only problem with this is that little bit of, you can see the blood is trying to come out. So that's the strip of the trabecular meshwork that has come out. You can go use a forceps to go in and try to remove that. So a little bit of bleeding intraoperatively does happen, and at the end of the surgery, we can try and clear the anterior chamber of the blood. And maybe I'll forward a little bit. So you can use an irrigation aspiration to try and remove it. So with the IA probe, I was trying to peel off the torn trabecular meshwork strip, but it was not easy to do so. Then I used a forceps to go and remove it. So it's a very simple procedure. Post-operatively, you continue the regular medications that you're continuing. So this is a forceps, micro forceps that is used to go and strip off the torn trabecular meshwork. Okay, so these are post-operative pictures. The good thing is that day one post-op, the eye is crystal clear. You may have microhyphema. Most often you may not even see that. And you can see the arrow pointing out here on a gonio picture where there's a cleft. And in our series, what we have seen is close to 88% of these eyes had more than one anti-glaucoma medication drop at 6 months. And that is the follow-up that we have, which is good. Like I said, again, this is not a procedure that is done in patients who require a really good intraocular pressure control, or somebody even with medications don't have a good pressure control. This is not something that is indicated. Suprachoroidal shunts are used. This is a SIPA stent, but in August 2018, based on the COMPASS trial, because of the low endothelial cell count over a 5-year follow-up, this has been withdrawn from the market. There are other ab externo procedures like the Stegman canal expander and the suprachoroidal gold shunt, but then again, these are something that we don't have any experience with. Subconjunctival implant or the Aquasis or the Zen implant is something that is being used. Again, this is an ab interno one, a collagen derived gelatin which is inserted into the subconjunctival space. In focus microshunt, I think of all the ones that are available is very promising. It is a small arrowhead kind of a shape that is there, very tiny one. You can see this a picture on the finger. It has a tube which is inserted in the anterior chamber, and it also has a very small outlet which is placed in the subsclerally in the subconjunctival space. So it also, so you can see a picture here. It causes a very, very controlled drainage of the aqueous apparently, and you may have a very low-lying bleb or maybe a diffuse kind of a conjunctival elevation, but not actually a bleb that is formed. But then we do have very limited experience, and this is not available in India yet, but that is quite promising. What do these MIGS actually help you with? They do produce decrease in intraocular pressure, but not a very great amount of decrease in intraocular pressure. What you need to look at is the number of medications. The number of medications, the lower panel here tells you, upper panel is the pre-op medications, and the lower one in red is the post-operative medications. So number of post-operative medications definitely have come down in with all these devices. And this is again a result which shows the reduction in intraocular pressure again could be quite variable, because several of these studies may not have actually washed off the patient with medications, may also have good control, and post-operatively also you will not see a good drop. But if you look at the total number of medications, significant drop is something that is seen. Where it is not indicated, definitely not in angle closures, you have significant synechial closure, not in advanced glaucomas where you want really good intraocular pressure control, definitely not in progressive glaucomas or those eyes with that require a lower target intraocular pressure, or somebody who have allergy to anti-glaucoma medications, you actually want to take them off all the medications. So again, MIGS may not be indicated in these eyes. So they are safer. Definitely it helps to decrease the number of anti-glaucoma medications, can avoid touching the conjunctiva, can bring down the intraocular pressure to mid-teens with no bleb and possibly no hypotony related problems and less complications. There are several MIGS that are available and definitely a lot more in progress. What do they have to offer us? Definitely have a great promise and increase use in the future, possibly, but one prohibitive thing is the cost that is involved. And most of them are combined with cataract surgery. How much intraocular pressure does it reduce? For how long is a question for which we do not have answers as of now. But yes, as time goes by, we will have better evidence. But the biggest problem, like I told you, and I would like to re-emphasize, is affordability. Affordability is a huge problem. So for that, just a little bit decrease in intraocular pressure of and decrease in the number of anti-glaucoma medications, do you or can you afford to provide this procedure at that cost is something that we will have to worry about. But yes, it definitely has a role in certain patients, and availability is a question. Thank you for your kind attention.
Thank you, Dr.